to the demo.
This was really good. This is the number of hits you will get if you enter left ventricular function to PubMed. And this is the number of hits you will get if you enter the same search term into Google's, over 7 million. So there must be something about left ventricular function which is very important. We asked a few colleagues what they think and why they think left ventricular function has such an importance in cardiology. And they came up with some very smart answers.
So let's think about clinical conditions where we really need left ventricular function. Where does it play a role? It's just extremely important in chemotherapy patients, in heart failure patients, maybe being prepared for heart transplantation. Are we getting anywhere with our cardiac medications? It's also important in nephrology patients, maybe undergoing hemodialysis. Left ventricular function is really the most important parameter that we need in cardiology. We just can't go without it.
After post-cardiac surgical intervention, you need to know how is the left ventricular function to know if you have to change or modify your therapy.
So to summarize, left ventricular function is important for diagnosis, for management, for prognosis, and for the follow-up of our patients. But the problem is, how do we quantify left ventricular function? Now, the heart is a very complex organ which twists and turns. And to quantify the function, theoretically, all you need to do is you need to measure the amount of blood that the heart ejects. We can do that actually with echocardiography. We can calculate parameters such as cardiac output, cardiac index, and stroke volume. But there is a simpler way. We look at ejection fraction. We'll talk about ejection fraction later, but before I do so, I would like to show you a case. This is the case of a 23-year-old law student who went to the disco with his friends, and while dancing, all of a sudden he fainted. Now, his companions thought he was drunk, brought him outside. They did call the ambulance. The ambulance came, and the patient had ventricular fibrillation and was resuscitated on site. Fortunately, everything went well. He arrived at the hospital, and one of the first things we did was an echocardiogram. Now, I'll show you this echo, and I'm sure you will agree that the patient has a severe cardiac problem. There's two things that you can note on this echo. The first is that his left ventricle is severely dilated. The shape is also very spherical. And the other thing is that its function is very, very poor. You can see that the ventricle also twists abnormally. The patient also had a left bundle branch block, which explains this synchrony. You can see that here nice in the four-chamber view. But the major finding here is that we can establish the diagnosis of dilated cardiomyopathy and also assess his left ventricular function. So what did we do with the patient? We implanted an implantable cardioverter defibrillator, an ICD, with a CRT system which corrects the synchrony, and we were able to help the patient at least somewhat. You can see that his ventricular function is a little better and that the septum now is more synchronous in its contraction. But the key point here is that if you want to assess patients with left ventricular function, you need to look at two special things: the size and the contractility of the myocardium. And this we will show you right now.
Having an idea on left ventricular size is extremely important, and measuring distances is easy, is quick, and you can actually do in every view. Sometimes in critically ill patient, you can remember only 1-2 views. I will show you now how to measure distances from 4 views. So actually, what I would do, start with a parasternal long axis view. You have to visualize the ventricle really good, and then measure distance between the septum and the posterior wall. I freeze and diastole and simply caliper. We measure from endocardial border to endocardial border, make sure of it, and this will be our measurement, 52 millimeter. Then we go to two-chamber view, then we go to parasternal short axis view, and we freeze our image. We have to see the papillary muscles and diastole. Here you can help yourself with the ECG, and again from the septum to the posterior wall we have the same exact value, it's 52 millimeter. Then I would go to 4-chamber view and again freeze your image. Remember, the distance has to be from here in 4-chamber view, lateral wall to the septum and between the mitral valve and the papillary muscles. Here we have 54, and actually these measurements should match because we are measuring at the same level of the ventricle every time. And I would also do in subcostal view, so I will ask my patient to turn on his back. And here, as soon as you have a good image, you freeze, you store, and you go back to the freezed image to take your measurements. And again, the measurements here to the border is 53 millimeter. And this is how you get really simple measurements of the left ventricle. Of course, in cardiology, you can get more sophisticated measurements, but to tell you the truth, in clinical practice, this is all you need. It's more than enough.
From size now to function. And to calculate the function, we will look at ejection fraction, which is defined as the percentage of blood which is ejected at each heartbeat. Now, to calculate this, you have to know what the volumes are at both end diastole and at end systole. And to do this, we use a method which is called the Simpson method or method of disc. Anna is now going to show you how to do this right on the echo machine.
When you want to assess left ventricular ejection fraction, you have to start by acquiring a good 4-chamber view and 2-chamber view. So I will make sure this time the quality of the image is really high. I will tell you why. Once you have these images, simply record them and then go back to the recorded images. You do this for 4-chamber view and 2-chamber view. It's extremely important to really focus on the left ventricle, so avoid foreshortening, but play with the depth in order to cut maybe the atria, but really see the ventricle. It's really important to make sure the lateral wall is inside the view, and it's not really easy to get it every time. And make sure you really see the endocardial border, because you will see when we start our measurement, we really need to freeze the image first, then start with the end diastolic volume. So I will use the ECG maybe, or simply use the left ventricle when it has the bigger size. That's the place you want to put and start your measurements. Then you simply follow the border, the contour of the endocardium, and remember, when you see the papillary muscles, you have to cut through them, reaching the mitral valve. So at the end, you click once, twice, and you get a measurement of the left ventricular and diastolic volume. So you move to the systolic phase. The ventricle will get smaller, 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 then open again with the mitral valve. So the instant before, that's end systole. You start again your measurement, following the border, cutting through the papillary muscles, and you will get a completely normal value of ejection fraction, which for this young man is 71%, so it's extremely normal. Then you perform the same measurements in a 2-chamber view and you will get a biplane value.
I'm sure you agree that the image quality in the patient we just showed you was terrific, so there it's quite easy. But image quality is a limitation in many patients, and you need a lot of experience to also know where you should contour the ventricle. Furthermore, don't forget that very frequently we don't have the very tip of the apex into our field of view, and this means we'll underestimate the true volumes. In addition, understand that if we use biplane Simpson, it is not truly three-dimensional. We only have two cut planes, and so we're going to miss part of ventricular function, especially in the posterolateral wall and the anterior septum. And finally, it's time-consuming. So we will be looking for other methods that will give us an ejection fraction more quickly. Now, the industry has new technologies in some machines already implemented where you simply press a button and you get an automatic ejection fraction. This is a neat thing to have. Of course, you usually have to have some kind of interaction, and you have to watch out because these systems are not always 100% reliable. But there is a number of different technologies which are helping us to calculate and to look at ejection fraction. One of these technologies is contrast imaging. This is just an example. I show you that hopefully will make you more interested to go further in your echo career. It is a technology where you inject a contrast via the vein and which contrasts the left ventricle. Just take a look at the image on the left and on the one on the right, and you can clearly appreciate that now with the contrast on board, it is much easier to quantify ejection fraction. But no matter which technique of calculating cardiac function you use, automatic EF or Simpson method or even eyeballing, keep a few rules in mind. The first is that ejection fraction does not necessarily correlate with cardiac output. For example, you might have a patient who has poor ejection fraction, but he's well compensated, and at least at rest, he can still generate enough stroke volume to keep him basically alive or to have a normal stroke volume. Rule 2. We tend to overestimate function in small ventricles. Why is that so? Here's a video that will explain this to you. Now observe these 4 different ventricles, each with a different size and a different left ventricle function. And we'll look at the stroke volume. Now, if we look at this normal ventricle, let's say he's generating 80 milliliters of stroke volume. To do that, he needs an ejection fraction of 60, and this area in blue would be the distance that the endocardium travels, in other words, the contractility. Now, if you compare a ventricle which is a little bit larger, has less ejection fraction, for him, or for this ventricle to generate the same stroke volume, he does not need to move as much as the ventricle which is normal. In other words, with less contractility, it is able to generate the same stroke volume. And this is even more pronounced in this ventricle, which is very large. Again, the same stroke volume, but in this case with very little wall motion. So all of these ventricles do the same thing, but they do it differently. This one with little motion, but with a large ventricle, while this ventricle here on the left, which is now smaller than normal, has to contract very, very vigorously to generate the same stroke volume. So in essence, if we have such a ventricle, we might think, yes, he's doing fine because he has a high ejection fraction, but in essence, it's doing not much more than a normal ventricle, but he is already on the upper limits of what he can do. So, rule 2 again, we tend to overestimate ejection fraction, or left ventricle function rather, in patients who have small ventricles. To exemplify this a different way, take a look at this balloon which is being inflated. Now, with each pump of air, we see an increase in the size of the balloon, but this increase gets less the larger the balloon is. That's exactly the same thing as with left ventricle function. And the last important rule is we tend to overestimate left ventricle function in the setting of aortic and mitral regurgitation, where we have volume overload. In these cases, we have some form of reduced afterload, which means that the ventricle is pumping, getting less resistance, which makes it look better than it really is. To summarize, rule 1, ejection fraction does not correlate with cardiac output. We tend to overestimate function in small ventricles, and we overestimate ejection fraction in mitral or aortic regurgitation. Keep this in mind. But we're not done yet. There's another way of looking at left ventricle function, and that is the so-called EPSS, which is the E-point septal separation, a technique that the emergency physicians really love. It's really easy to measure the E to septal distance. All you need to do is acquire a good parasternal long axis view, like the one I'm showing you right now, and then you simply freeze the image and scroll to the position where the mitral valve is at its greatest opening. That would be right here. And then you measure the distance from the septum to the tip of the leaflet. In this case, 0.5. Now, this is obviously a normal opening of the mitral valve, simply because his cardiac output is high, he has a normal sized ventricle, and his function is okay. But the nice thing about the E to septal distance is you can even acquire it in atypical views. I'll show you this. Now I'm moving down a few intercostal spaces. And here I'm freezing the image now. And see, again, we get a distance which is very similar to the one that we got in the optimal view. All you need to do is you need to get a very good parasternal long axis view like the one I'm showing you right now. And then you simply freeze the image, you measure, but you can also get it from an intercostal space which is a little bit lower. For example, from right here. So you don't even have to know how to image. So in essence, very simple, very easy, very global information about left ventricular function. Here's another example. Look at the motion of the anterior mitral valve leaflet, and now we'll just stop it right here at the moment when it is closest to the interventricular septum, and right here would be the distance that we would measure, the EPSS. Very small, so one can assume that left ventricular function is normal. Compared with this example here, poor left ventricular function, we don't have much opening of the mitral valve. Again, we'll freeze, and now we have a very large distance here. So just by this measurement, you can tell that left ventricular function is poor. Of course, just by looking at the ventricle, you can probably do the same thing. Now remember that both the size of the ventricle and the function are kind of computed with this parameter. Here again, the comparison between the two. On the left, very good function. On the right, very poor left ventricular function. Well, studies have shown that an EPSS of more than 7 millimeters corresponds to an ejection fraction of less than 30%, and that this parameter is highly sensitive and specific. From measuring ejection fraction to estimating ejection fraction. Remember, in the very first chapter, we already trained your eye to eyeball left ventricular function. We'll expand on that and show you some additional tricks. To also repeat what we taught you in the very first chapter, here are the things that you should be looking for if you visually assess left ventricular function. The first thing is the inward motion of the myocardium in all the different regions of the myocardium. Okay, also at the apex. The next thing is thickening of the myocardium. Okay, and the last thing is the motion of the mitral annular plane towards the transducer and away from the transducer. Now, if we take a look at a ventricle which has normal contractility and look at the septum, you can clearly see that the myocardium is thickening in all its different regions, everywhere. And this is an important finding that you should be looking for. And now we can compare it to a ventricle which does not have normal left ventricular function. Look at the inward motion. Again, much less than in the previous example. Yeah, you can see that the contour hardly moves away from this line here. Then we look at the motion of the annulus. It hardly moves. See, it stays put. And then look at the thickness of the myocardium. It hardly changes. So if you just obey these three rules, inward motion, myocardial thickening, and annular plane motion, I'm sure you will be able to judge ventricular function in most patients. And how would you judge left ventricular function in this short axis view? Well, definitely it's better than the one we saw previously, but it's still not normal, especially in this region here. If you take a look at the motion of the endocardium right here, you see that it hardly moves. It moves a lot better down here. Okay? And we also see that the thickening of the myocardium is not completely normal in this region. So what we have here is we probably have some degree of wall motion abnormality. And In essence, I would judge it as mildly reduced. To communicate your findings to the referring physician or to put something into your report, you need some form of a grading scale. And the grading scale that we use is basically a 4-point grading scale where we have a normal ventricle as 0, -1 if it's hyperdynamic. If it's mildly reduced, we call it 1, 2 is moderately reduced, and 3 is severely reduced. And to put the ejection fraction values here in perspective, everything that is above 70 would be hyperdynamic, between 55 and 69 normal, between 45 and 54 would be mildly reduced, between 30 and 44% moderately reduced, and severely reduced is below 30. But keep in mind, you might also have catastrophic left ventricles, which could be maybe even graded as grade 4, where you have ejection fractions somewhere in the range of maybe only 5 or 10%. I know, lots of information, but we're not completely done yet because we still have part 2 on left ventricular function. And in this part, we'll teach you why patients have left ventricular dysfunction, and we'll show you more tricks that will make you more secure in your patients.